I'm Dr. Carol Benson. I'm from Brigham and Women's Hospital in Boston and Harvard Medical School. The title of my lecture is Fetal Gastrointestinal and Genitourinary Tract Ultrasound. My lecture today will cover anomalies of the fetal gastrointestinal tract and genitourinary tract as found by ultrasound. During a routine obstetrical ultrasound, the images that we take in the fetal abdomen include the abdominal measurement, which is taken at the level of the stomach and intrahepatic portion of the umbilical vein. We take images of the kidneys, the urinary bladder, and we take a view of the anterior abdominal wall at the umbilical cord insertion. On the abdominal measurement, the first thing we look for is the stomach. We want to see that the stomach is present in order to exclude such anomalies as esophageal atresia or diaphragmatic hernia. We assess the stomach location to make sure it's in the left upper quadrant to exclude such anomalies as situs inversus or situs ambiguus. Then we look at the stomach size because the stomach may be enlarged in situations of bowel obstruction. And lastly, on the view of the fetal abdomen, we also look for other fluid collections besides the stomach in order to identify anomalies such as duodenal obstruction or to look for dilated loops of bowel or intra-abdominal cysts. This is a view of the measurement of the fetal abdomen. You can see that we measure it where the fetal abdomen is round, and on the view where we see the stomach and the intrahepatic portion of the umbilical vein, you'll notice that no other cystic structures are seen on this view. When the stomach is not visualized, this is sometimes a normal finding. The stomach may be empty if the fetus hasn't swallowed within the last few minutes, but during the course of an entire exam, we should see the stomach at least within a 30-minute period, and if we don't, we should bring the patient back to see if the stomach is in fact absent or was just empty during that exam. Causes of an empty stomach include anomalies such as esophageal atresia, a left diaphragmatic hernia where the stomach is not in the abdomen but rather up in the chest, cleft lip or cleft palate preventing the fetus from swallowing, anomalies of the central nervous system, and situs abnormalities where the stomach is somewhere besides the left upper quadrant. Also, in cases of severe oligohydramnios, we may not see the stomach because there's no fluid for the fetus to swallow. So here, for example, is a fetus at 18 weeks gestation where no stomach was seen throughout the entire examination. You can see a view of the upper abdomen here where no stomach is seen, and then a magnified view of that same fetus where no stomach was found. We didn't see a cause for this problem, and so when the patient was brought back, here she is at 21 weeks, and now we understood why the stomach was empty. This fetus has a bilateral cleft lip. You can see on this view we have the lower lip here, the mouth slightly open, and here we have a cleft in the upper lip on either side with this maxillary prominence in between. Now on the clip you can see this cleft with the maxillary prominence in the middle of the upper lip and the cleft on either side of that and the cleft palate behind as we take the clip through. This fetus did not have a stomach in the left upper quadrant, but rather in the right upper quadrant. Here you can see it here. And when we take a view of the lower thorax in the same fetus, we see that the heart is on the right as well, rather than on the left. So this is a case of complete situs inversus. We also evaluate the fetal abdomen to look at the bowel. Typically the bowel is homogeneous and not as echogenic as bone, but sometimes it is as echogenic as bone, and this can be associated with abnormalities including cystic fibrosis, intrauterine growth restriction that will develop subsequently, trisomies 21 and 18, and also with swallowed blood. So here's an example of a fetus with echogenic bowel at 18 weeks gestation. You can see this small clump of bowel on these two images is very bright as the bone we see here at the iliac crest. And this fetus proved to have trisomy 21. This is a view of the fetal heart in the same fetus, and you can see that there's an AV canal deformity, a complex congenital anomaly of the heart associated with trisomy 21. This fetus also has echogenic bowel at 18 weeks. You can see this clump of bowel is quite bright, similar to the echogenicity of bone, and this was due to a fetus who had there was a subchorionic hematoma, and the fetus had swallowed some of the blood that has creeped into the amniotic fluid. You can see that large subchorionic hematoma extending down across the cervix. Amniotic fluid is important for the development of the fetus, and the amniotic fluid volume is maintained by a homeostasis between the fetal renal function and the fetal ability to swallow and absorb the fluid in the gastrointestinal tract. So it requires the fetus to swallow the fluid and then process the fluid, but it also requires the fetus to urinate into the amniotic fluid to replenish the fluid, and that provides our amniotic fluid balance. When there's diminished or absent swallowing, then there will be inadequate amniotic fluid passed into the gastrointestinal tract and therefore inadequate fluid resorption, and so polyhydramnios will develop inside the uterus, extra fluid surrounding the fetus. This is helpful in pointing us in the direction of anomalies of the gastrointestinal tract, because in the presence of polyhydramnios, we do want to look for gastrointestinal obstruction. And in fact, the greater degree of the polyhydramnios is, the more proximal the obstruction is likely to be. The obstruction can be at the level of the esophagus, the gastric outlet, the duodenum, jejunum, ileum, even the colon. With esophageal atresia, typically there's very severe polyhydramnios. This is a very high obstruction, and we'll look in the fetal abdomen and find either an absent stomach or a very small stomach. So here's an example of a fetus with esophageal atresia. These are views of the thorax with the fetal heart beating and views of the upper abdomen. Notice how much amniotic fluid there is. There was severe polyhydramnios around this fetus, and looking through the fetal upper abdomen, we could not identify a stomach anywhere in this fetus because there was obstruction of the esophagus. This is another fetus with esophageal atresia. This fetus, though, had a tracheoesophageal fistula, so we were able to identify fluid in the fetal stomach. Notice the stomach in the left upper quadrant. There was only moderate polyhydramnios in this case. But what was interesting in this case is that we could identify the blind loop of the upper portion of the esophagus. This fetus had its neck extended, and we saw a little bit of fluid behind the trachea. And as we watched this fluid, we saw it expand and move inferiorly and expand a little bit more, but not travel any more inferiorly. So this is fluid that the fetus has swallowed, but is obstructed at the level of the atretic portion of the esophagus. So this fluid will then track back out into the amniotic space. Gastric outlet obstruction is rare. It's the most rare form of gastrointestinal obstruction, and it's typically due to pyloric atresia, either primary during the development of the pylorus or secondary to a vascular accident or insult in utero. The findings will be a dilated stomach as well as polyhydramnios. So here's a 35-week fetus. It was surrounded by mild polyhydramnios and had a dilated stomach, and then no fluid seen beyond this point, and this was due to gastric outlet obstruction. This is the baby after birth. You can see a markedly dilated air-filled stomach, but no air past the stomach into the neonatal abdomen. The gastrointestinal tube has been passed in through the esophagus down into the stomach. Duodenal obstruction can be caused by atresia at the second portion of the duodenum, or a web, or due to an annular pancreas. The ultrasound findings are characteristic. There'll be polyhydramnios, but there'll also be the classic double bubble sign, which is two dilated or fluid-filled structures in the upper abdomen. Duodenal atresia is associated with other anomalies in over 50% of fetuses, and therefore, when you do see that double bubble sign, look carefully at the rest of the fetus for other anomalies, including the skeletal anomalies or vertebral anomalies. Look elsewhere in the gastrointestinal tract, but also look at the heart. In addition, duodenal atresia is associated with trisomy 21 in about 30% of cases. So consultation and counseling for amniocentesis or testing for karyotype is important when this anomaly is identified. And this is the typical finding. On the transverse view of the upper abdomen at the level we would normally measure the abdominal circumference or diameter, we see 2 bubbles rather than 1. We see the stomach in the left upper quadrant and then a second bubble in the right upper quadrant. And if you move inferiorly, you can often find the connection between these 2 bubbles, as we see here, through a mildly dilated pylorus. So this is the dilated stomach and this is the dilated duodenal bulb. Bowel obstruction distal to the duodenum can occur in the jejunum or the ileum due to atresia, which is most often the result of a vascular accident. But there can be other obstructions at the level of any of these, including the colon, due to a volvulus, due to meconium plug, or intussusception. The findings are dilated loops of bowel and polyhydramnios. The more proximal the obstruction, the greater the polyhydramnios, and the fewer the loops of bowel. The more distal the obstruction, the more dilated loops you will see, and the less degree of polyhydramnios. So here's a fetus with a fairly proximal intestinal obstruction. At the level of the jejunum, we see 1 dilated loop of bowel here, peristalsing, but this cannot process the fluid past this point, and we see mild polyhydramnios here. This fetus has ileal obstruction. Notice on the 2 clips that there are multiple dilated loops of bowel filling the fetal abdomen. These have active peristalsis, but the fluid cannot pass beyond the point of obstruction. I do want to point out that these dilated loops of bowel do extend to the periphery of the abdomen. Normally at the periphery of the fetal abdomen we'll have colon with small bowel loops in the center. But when the small bowel dilates, it will expand all the way to the periphery of the abdomen. And we know this is small bowel due to the folds crisscrossing the loops of bowel. If there is a bowel obstruction and the small bowel perforates such that the contents spill into the peritoneal cavity, this is called Meconium Peritonitis. The meconium spills into the peritoneal cavity and causes a chemical peritonitis that leads to the accumulation of fluid in the abdomen. So initially at the time of perforation, we'll see ascites in the fetal abdomen. But then the peritoneal cavity will wall off the fluid and form cysts that will have calcifications develop in the wall of the cyst. And eventually, the cystic fluid may be completely resorbed, leaving peritoneal calcifications scattered throughout the peritoneal cavity. So here's a fetus in whom we followed the progression of meconium peritonitis from 16 weeks to term. At 16 weeks gestation, we saw that there was ascites in the fetal abdomen, but no other sign of hydrops, so the only finding was this free fluid in the abdomen surrounding loops of bowel. At 21 weeks gestation, the fluid had been walled off into a single cyst adjacent to the umbilical cord insertion, and this cyst had some calcification along the wall. By 25 weeks gestation, the calcifications were now scattered throughout the peritoneal cavity, but the cystic fluid had been completely resorbed. This clip passes through the site of the previous meconium cyst, which probably was here, and now we're left with a dense clump of calcification. But elsewhere in the abdomen, we also saw calcification, as we note here around the edge of the liver and here along the wall of the peritoneal cavity. Sometimes the bowel has inadequate fixation of the posterior mesentery so that it can spin around on itself. This leads to incomplete rotation of the bowel, and when it spins around completely on itself, we may have a small bowel volvulus, which can cause gastrointestinal obstruction, as well as necrosis of a loop of bowel. On ultrasound, there's typically acute onset of polyhydramnios and then acute onset of dilated loops of small bowel proximal to the site of the volvulus. There may be a single, larger, more dilated loop representing the loop of bowel that twisted on itself. And we may see what's called the whirlpool sign, where you see the twisting around and around of the bowel. So here's a case of a volvulus where we have that whirlpool sign. You can see on the still image a dilated loop of bowel that spins around on itself, and when we look at the clip we can see it curls around and around and around. Here is the big dilated loop, and then as we come down we see it curling around itself. This is called the whirlpool sign. These are loops of bowel twisted on themselves that will obstruct the flow of fluid and contents in the gastrointestinal tract. Here's one later, along in gestation, a different one where there was a volvulus. You can see this single, very large dilated loop of bowel, and then you can see on the clip some smaller dilated loops of small bowel proximal to the site of the volvulus. Also notice there's some free fluid. This loop of bowel was necrotic by the time the baby was born. Now we assess the anterior abdominal wall at the umbilical cord insertion to make sure that the only thing that crosses the anterior abdominal wall are the vessels making up the umbilical cord. If we see other things protruding from or crisscrossing the anterior abdominal wall, that could be an omphalocele, a gastroschisis, or due to amniotic band syndrome. So normally on a transverse view of the abdomen at the cord insertion, we should see the umbilical cord passing into the fetal abdomen and the rest of the abdominal wall intact. An omphalocele is a ventral wall defect at the umbilicus. This defect allows abdominal contents to herniate into the base of the umbilical cord. This defect is covered by a peritoneal membrane, so it has a rounded contour. One of the important things to remember is that omphaloceles are commonly associated with other anomalies and with aneuploidy. So a very careful fetal survey is warranted when an omphalocele is diagnosed, and counseling for karyotype assessment of the fetus is also important. Here is a sagittal view of a fetus with a large omphalocele. You can see this mass protruding from the anterior abdominal wall. It has liver as well as bowel within this mass. Notice its rounded contour because it is contained by a membrane. On transverse view, we see the rounded mass protruding from the anterior abdominal wall. The stomach has been pulled forward in the fetal abdomen. Notice the umbilical vessels traveling through this mass and out the other side. These are two 3D images of a fetus with an omphalocele to show you its cute rounded contour. See this rounded mass sitting in front of the anterior abdomen of this fetus. Very smooth contour because of the membrane containing it. Here's another fetus with a very large omphalocele. This is the fetal abdomen with the stomach here. You can see the umbilical vessels traveling into this very large mass protruding anteriorly from the fetal abdomen at this abdominal wall defect. On the 3D view, you can see the fetus draped around this very large ball of the omphalocele mass. Now, gastroschisis is a para-umbilical defect. That is, it's next to the umbilical cord, not at the umbilical cord. This defect allows abdominal contents to herniate directly into the amniotic cavity. It is not covered by a peritoneal membrane, so the abdominal contents will have an irregular contour and spread out in the amniotic cavity. In general, gastroschisis is not associated with other anomalies. It is interesting that gastroschisis seems to be found more often in young mothers, those under the age of 20 or in their early 20s, rather than with older mothers. The chromosomes are usually normal. About 40% will have dilation of the bowel prior to delivery, and about 80% will have postnatal complications related to the repair of the gastroschisis. The complications include things such as infection or gastrointestinal complications such as vomiting, reflux, constipation, and fistula development. On ultrasound, when a gastroschisis is present, we should see a normal cord insertion, and then adjacent to the cord is where we'll find the defect or the mass of the herniated structures. These are two clips from a fetus with a gastroschisis. Notice the normal cord insertion into the fetal abdomen, and then notice adjacent to that is this lobular mass protruding from the anterior abdominal wall. You can see that the mass is interspersed with amniotic fluid because it's not contained by a membrane. Here's another one. This fetus has a gastroschisis. You can see multiple loops of bowel protruded into the amniotic cavity from the fetal abdomen. The defect is adjacent to the umbilical cord insertion. And here on the 3D view, you can see the individual loops of bowel that have protruded from this fetal abdomen. And you can see it doesn't have that smooth contour that we saw with the Omphalocele. This is an interesting case. This fetus proved to have a gastroschisis, but we made the diagnosis late in pregnancy because of delayed herniation of bowel through the defect. At 22 weeks gestation, we saw a little bump protruding from the anterior abdominal wall, and we thought this might be a dermal lesion, something related to the fetal skin, because everything else was completely normal. On follow-up scan at 26 weeks, now this lesion was just a little tubular structure. It was this small little tube protruding next to the umbilical cord insertion. We still didn't have any idea that this was a gastroschisis, but when she came back at 36 weeks gestation, now we see many loops of bowel protruding from the anterior abdominal wall into the amniotic cavity. So sometimes these may have a delayed protrusion of the abdominal contents until the fetus grows bigger and the defect gets large enough for the loops of bowel to pass out into the amniotic space. We'll now move on to the genitourinary tract. In a routine obstetrical ultrasound, we evaluate the kidneys and the bladder of the fetus. But if you see abnormalities of the kidneys and/or the bladder, it's important to look for the ureters, and it's also important to assess the genitalia of the fetus, not just when there are abnormalities of the kidney and the bladder, but also in other situations where it's important to know the sex of the fetus and to see if the genitalia has formed properly. We assess the kidneys first to see if they're present. They could be absent, such as with renal agenesis. We look at their location because sometimes they're present, but not in a normal location, but rather in an ectopic location. We look at their size and their echogenicity to exclude dysplasias or autosomal recessive polycystic kidney disease. And then we look at the collecting system to make sure the kidneys are not obstructed. Normally, we'll see a kidney in each renal fossa. So when we scan from along the posterior aspect of the fetus, we'll see the spine in the middle with shadowing coming down, and we'll see a kidney in each renal fossa on either side of the spine. Typically, the kidneys are more hypoechoic than the bowel anteriorly. They may have an echogenic capsule around them, and they may have somewhat increased echogenicity in the middle at the renal sinus. On longitudinal view, the kidney will be oblong or kidney bean shaped, and there will be hypoechoic areas visible due to the hypoechoic medullary pyramids. These should not be confused with hydronephrosis or cysts. Now, I mentioned that amniotic fluid was a balance between the fetus's ability to swallow and resorb the fluid and also the fetus's ability to replenish the fluid by urinating into the amniotic cavity. In the absence of renal function, the pregnancy will develop severe oligohydramnios. With severe prolonged oligohydramnios, changes in the fetus will develop, including pulmonary hypoplasia, abnormal facies, and limb positional abnormalities. In fact, if the oligohydramnios is so severe, the pulmonary hypoplasia may be so severe that the fetus cannot survive after birth. So in a fetus who has bilateral renal agenesis, on ultrasound we'll see very severe oligohydramnios. We will not be able to find the kidneys and bladder, but we might see the adrenal glands located longitudinally with respect to the spine. Fetuses with bilateral renal agenesis cannot survive after birth because of their pulmonary hypoplasia. They do not have lungs that can support respiration. So here's a fetus with bilateral renal agenesis. You can see on this transverse view of the fetus that there is virtually no amniotic fluid around this fetus. You'll see the same on the two longitudinal views. No amniotic fluid whatsoever inside the amniotic cavity. On longitudinal view, we saw the adrenal glands lying parallel to the spine. On transverse view, we saw no kidneys in either renal fossa. And this was also confirmed with the power Doppler showing no renal arteries coming from the aorta. Now, unilateral renal agenesis is compatible with life because the single kidney can grow and develop into that of larger than a normal kidney. It's compensatorily enlarged and has a compensatorily increased number of tubules to process the urine. On ultrasound, we'll see one kidney in a renal fossa and then no kidney in the contralateral renal fossa. We will look carefully. We will be able to see the adrenal gland lying longitudinally or parallel to the spine. And we should then look at the size of the single kidney to note that it's abnormally enlarged for gestational age. So here's one such case. On a transverse view of the back of the fetus, we see the left kidney is in normal location and there's no kidney in the right renal fossa. And on the longitudinal view of the aorta, we see a nice left renal artery and no renal artery extending to the right side of the fetus. When we look in the right renal fossa, there is no kidney longitudinally seen, but we see the adrenal gland lying down or lying in parallel to the spine because it's not pushed up by the kidney. If we don't find a kidney in the renal fossa, the next thing to do is see if it's somewhere else inside the fetal abdomen as opposed to absent. Renal ectopia is sometimes seen, and the most common location for an ectopic kidney is in the pelvis. Next most common are if the kidney is fused to the contralateral side, called cross-fused ectopia, and we also can have kidneys that are fused across the midline, called a horseshoe kidney. With the pelvic kidney, we'll see an empty renal fossa with the adrenal gland oriented longitudinally. We'll see a normal kidney on the other side with the adrenal gland topping it. And when we look in the pelvis, we'll see the pelvic kidney sitting next to the urinary bladder. The contralateral kidney will be normal in size rather than compensatorily enlarged. So here's a fetus with a pelvic kidney with a little bit of fluid in the collecting systems of each of the kidneys. We see on a transverse view of the fetal abdomen that we have one kidney here with a little fluid inside it, but no kidney in the contralateral renal fossa. This is the left side, and when we look at the left fetal longitudinally at the left renal fossa, we see the adrenal gland is oriented longitudinally, parallel to the spine. So we then want to go find the other kidney. And so when we look in the lower portion of the fetal abdomen, we see there's a kidney here down in the pelvis. So we have the normal right kidney with a little fluid, and then we see a left kidney here with fluid in the collecting system. With cross-fused ectopia, the kidney on one side has fused with the lower pole of the contralateral kidney, so both kidneys are on the same side, or both kidneys are connected. The kidneys are usually fused at the lower pole, and they may take a right turn, so they may be L-shaped, or it just may be a particularly long kidney. So here's an example of a cross-fused ectopic kidney. We saw when we scanned in the renal fossa that there was a kidney on the left side, no kidney on the right side. The adrenal gland was oriented longitudinally, and so we looked a little more closely at that left kidney, and as we traveled down inferiorly, we could see that the kidney had an L-shaped, with both kidneys fused together at the lower pole of the left kidney and the upper pole of the right kidney, so that this was a cross-fused ectopic kidney. Here you can see the right kidney sits superior to the bladder. And here's just a clip through that so you can get a better look at it. We notice that with the powered Doppler also we see no right renal artery, but we do see the left renal artery, and then on the clip we see the L-shaped to that cross-fused ectopic kidney. With the horseshoe kidney, both kidneys are ptotic, that is, in a lower position in the fetal abdomen, and they're fused at their lower poles across the midline in the lower abdomen, so that they have a U-shaped, as we can see here on the diagram. This can be a difficult diagnosis to make because when we scan from the back of the fetus, we will see a kidney on either side of the spine, so we may not notice that they are fused across their lower poles. The way to identify this is to scan and identify renal tissue in front of the aorta and the inferior vena cava. So this is a view of the lower abdomen at the level of the bladder. We can see the aorta and the inferior vena cava, and we can see that the renal tissue connects all the way across the midline from one renal fossa to the other. And then on the clip, we can confirm that this is, in fact, a kidney fused across the midline in a horseshoe configuration. One of the most common anomalies of the fetus is hydronephrosis. This is identified by fluid inside the kidney. Now, sometimes there's fluid inside the fetal kidney, but this is not, in fact, an anomaly, and in fact, the fetus will be normal at birth. So we do need to identify these fetuses, and then they need to be followed up after birth. We diagnose hydronephrosis when we see dilated calyces in the fetal kidney, or when the fetal renal pelvis measures 7 millimeters or more from 16 to 20 weeks, or 10 millimeters or more after 20 weeks. But there are some fetuses who have mildly dilated renal pelvises that might or might not have problems after birth. And we do want to identify these in utero so that they can be properly assessed after birth. And we identify these by our reports saying possible hydronephrosis when the renal pelvis measures 4 to 6 millimeters from 16 to 20 weeks, or 5 to 9 millimeters after 20 weeks gestation. So here is an 18-week gestation. We can see that there's mildly dilated renal pelvises on each side measuring 6 millimeters, so we would report this as possible hydronephrosis. But this fetus, we would say, has hydronephrosis because there is calyceal dilatation inside the kidney. When we first identify hydronephrosis, we do recommend that these are followed during gestation because some of these will resolve, but some will remain unchanged and some will progress. So follow-up is important because we don't know which way it's going to go. Here's a fetus at 18 weeks gestation. The fetal renal pelvises measured 4.8 millimeters on each side, so this fell in the category of possible hydronephrosis. Notice that there's normal amniotic fluid because there's not urinary obstruction, so the fetus is able to replenish the amniotic fluid. We see fluid in the bladder and fluid in the stomach. But on follow-up scan at 24 weeks gestation, we now had mild oligohydramnios, so the renal function had, the replenishment of amniotic fluid had diminished, and we now had severe hydronephrosis of the kidneys on each side and a dilated urinary bladder and a dilated posterior urethra. This was a case of posterior urethral valves that presented itself later in gestation. We did a study looking at almost 1,000 fetuses with dilated renal pelvises and caliectasis, sometimes with caliectasis, sometimes not, and we looked at the postnatal outcome to see how often it is significant, depending on what the degree of hydronephrosis was, whether it was mild, moderate, or severe. And the way we classified it depended on gestational age. We classified it as mild when it was 4 to 7 up to 27 weeks gestation and 5 to 9 at 28 weeks to term. We classified it as moderate when it was 8 to 10 from 16 to 27 weeks, or 10 to 15 from 28 weeks to term, and severe when the AP dimension of the renal pelvis measures more than 10 before 27 weeks gestation and more than 15 after that. This was a collaborative study between us at Brigham and Women's Hospital and the Boston Children's Hospital. And here is a summary of our results. What we found is in fetuses who had mild hydronephrosis and no caliectasis, 20% had resolved by birth, but of all of those, only 9% required surgery ultimately, so 91% never required surgery. When there was mild hydronephrosis and caliectasis present, again 20% resolved by birth, and in this case only 14% required surgical repair, so 86% required no surgical correction. With moderate hydronephrosis, 12% resolved by birth, 21% required surgery, but when it was severe, over half required surgical correction after birth, 63% did. and only 5% resolved by the time the baby was born. So you can see that the degree of hydronephrosis does predict whether or not it will resolve by birth and whether or not the problem requires surgical correction after birth. Overall, in the fetuses who did require surgery, these are the diagnoses. The most common requirement for surgery was for ureteropelvic junction obstruction and for vesicoureteral reflux, and then there were a smattering of other diagnoses in our children after birth, including posterior urethral valves, ureterovesical junction obstruction, ectopic ureterocele, prune belly syndrome, neurogenic bladder, and cloacal anomalies. So ureteropelvic junction is the most common cause of neonatal hydronephrosis. It's a functional obstruction. About 30% of cases will have a bilateral obstruction, and fortunately this rarely develops into a dysplastic kidney, so they often do not need surgery. Here's a fetus with a ureteropelvic junction obstruction on one side. We can see a normal kidney on the contralateral side and a markedly dilated renal pelvis measuring 13 millimeters. On a sagittal view of the kidney, we see the dilated renal pelvis as well as dilated calyces. Here's a fetus who at 19 weeks gestation had a very mildly dilated renal pelvis at 4.7 millimeters. For us, this would be classified as possible hydronephrosis. But by 32 weeks gestation, we can see this had progressed to a large ureteropelvic junction obstruction. We see the renal pelvis now measures 14 millimeters, and we see calyceal dilatation inside the kidney. Now, vesicoureteral reflux results when there's abnormal insertion of the ureter into the urinary bladder, and this leads to reflux of urine from the bladder back up into the ureter and into the kidney, causing hydronephrosis and hydroureter. These ultrasound findings are exactly the same as what you'd see with another entity called primary megaureter. Primary megaureter is a different pathologic process with the same in utero ultrasound findings. The pathologic process with primary megaureter is that there is an aperistaltic segment of the distal ureter preventing the passage of the urine down the ureter into the bladder. So when we see hydronephrosis and hydroureter, we cannot say whether it will prove to be vesicoureteral reflux or primary megaureter. Here's a 17-week fetus. We see a dilated renal pelvis in the kidney measuring 6.7 millimeters, but we also see a dilated ureter extending from that dilated kidney down towards the bladder. So the best we can do is diagnose hydronephrosis and hydroureter, and the postnatal studies will find the cause. Here's another case. This is at 25 weeks gestation. We see a dilated renal pelvis, and then scanning inferiorly through the fetal abdomen, we see a markedly dilated ureter as it extends down to the bladder. Sometimes the kidney develops with two collecting systems. This is called a renal duplication. When this happens, it's not uncommon for the upper pole of the kidney to have an obstructed ureter, while the lower pole has a ureter that's not obstructed, but is more likely to demonstrate reflux. So here's a case of renal duplication, and we know it's a renal duplication because we have two different levels of hydronephrosis in the kidney. The upper pole is more dilated than the lower pole. Furthermore, we can see the dilated ureter extending down to the bladder to a ureterocele, which is an obstructed insertion of the ureter. So here's the kidney. We can see that there's a dilated upper pole. We can see that the lower pole also is dilated, but not as dilated as the upper pole. And then when we look in the abdomen below the kidney, we see the dilated tortuous ureter down to the bladder, this is the bladder. This is a ureterocele in the posterior aspect of the bladder. Renal dysplasia occurs when there's obstruction of the kidney after it's already formed. This obstruction, when it occurs later in utero, such as after 10 weeks gestation, or when the obstruction is incomplete, leads to thinning of the renal cortex and increased echogenicity of the renal cortex. We may even still be able to see hydronephrosis in that kidney. Now there's another form of renal dysplasia which happens when the obstruction is very early, and this leads to a multicystic dysplastic kidney if this early obstruction is complete. So with renal dysplasia with incomplete obstruction or delayed obstruction, we get a dilated kidney, we get markedly dilated hydronephrotic kidneys, but you'll also see marked thinning of the renal cortex, and the renal cortex will be very echogenic. So this is a fetus who did have posterior urethral valves, and the kidneys had become dysplastic. These kidneys will not provide renal function after birth. With a multicystic dysplastic kidney, the kidney is completely replaced by a large multicystic mass. This is typically a unilateral process. When it is bilateral, it's incompatible with life because there's no renal function in the fetus, and it's as though the fetus had bilateral renal agenesis. So the typical finding is we'll see in the renal fossa a cluster of cysts. Often this cluster of cysts is bigger than what a normal kidney would look like. So here on transverse view of the fetus, we see a little bit of one kidney, and in the contralateral renal fossa, we see a large cluster of cysts extending into the abdomen. We can see on longitudinal view that the renal fossa is filled with this cluster or mass, multicystic mass in the renal fossa. This is a multicystic dysplastic kidney, but we know this fetus will do fine because the amniotic fluid is normal, because the contralateral kidney is providing the renal function for this fetus. With autosomal recessive polycystic kidney disease, the kidney is non-functional or barely functional in most cases. This is autosomal recessive, so the parents have a 25% chance that this will occur in a subsequent child. It's characterized by renal failure and hepatic fibrosis. And overall, the severity depends on the degree of renal involvement in utero. On ultrasound, we'll see enlarged echogenic kidneys, severe oligohydramnios, and absence of the urinary bladder. So here's a fetus at 33 weeks gestation. Notice on the two images that there is no amniotic fluid. Very severe oligohydramnios is present. The kidneys are enormous. They fill the fetal abdomen. You can see these two kidneys measure more than 8 centimeters each, and a normal kidney shouldn't measure more than about 4 at birth. So these kidneys are very long. They're also very wide. You can see they extend anteriorly here and here, filling the fetal abdomen. But these kidneys, although they have a normal renal-form shape, are more echogenic than normal, and they don't produce urine because of the polycystic kidney disease. This is another fetus with autosomal recessive polycystic kidney disease. Both kidneys are enlarged. In this case, we can see multiple cysts inside the kidneys, whereas in the prior case, the cysts were too small to be seen with ultrasound. In addition to the renal cysts in this case, this fetus also already had a hepatic cyst. Now, another component of every second and third trimester ultrasound of the fetal anatomy includes finding the urinary bladder to make sure it's present. Absence of the urinary bladder might indicate absent renal function, such as bilateral renal agenesis, bilateral multicystic dysplastic kidneys, or autosomal recessive polycystic kidney disease. But another reason for absence of the urinary bladder is when there is exstrophy, so we can look for that as well. We also look at the size of the bladder in order to exclude posterior urethral valves. So here is a view of the fetus, a normal fetus. Typically we'll see the bladder in the pelvis by the end of the first trimester in all fetuses. Here's the bladder, here's the stomach, here's the liver. Posterior urethral valves is an anomaly that affects male fetuses predominantly or only. It is the second most common cause of hydronephrosis after UPJ obstruction. It's an obstruction at the level of the posterior urethra, which is the portion of the urethra at the base of the bladder. The ultrasound findings include oligohydramnios, dilated bladder and posterior urethra, hydronephrosis, and hydroureter. Sometimes the urine will spill into the abdomen, and you'll also see urine ascites. So here's a fetus with posterior urethral valves. You can see that there's oligohydramnios around the fetus. You can see that the bladder is dilated, and then we see a protrusion from the base of the bladder. This is the dilated posterior urethra. Also notice, you can see the kidney on one side is very dysplastic. It's small and echogenic. Here's another case of posterior urethral valves. Again, you see the markedly dilated bladder. We see the dilated posterior urethra protruding from the inferior portion of the bladder. And when we look at the kidneys, we see that the kidneys are hydronephrotic and dysplastic with thin echogenic cortex. Prune belly syndrome is also an anomaly that affects male fetuses. It's characterized by absence of the smooth muscle and abdominal musculature in the fetal abdomen as well as the urinary tract. It's characterized by dilated bladder, hydronephrosis and hydroureter, and often a dilated penile urethra. Now in this case, the fetus can replenish the amniotic fluid. It can pass urine from the bladder into the amniotic cavity, so there may be normal amniotic fluid, and typically there is never urinary ascites. So here's a fetus with prune belly syndrome. Notice the dilated urinary bladder. There's hydronephrosis, but there is still preserved renal cortex, and the renal cortex is not as echogenic as we see with the dysplastic kidneys of posterior urethral valves. In addition, when we look at the penis of this fetus, we see fluid in the penile urethra, so this is a dilated urethra. Bladder exstrophy occurs when there's an anterior abdominal wall defect through which the bladder is exposed to the amniotic space. The bladder may be exposed, or it may even be everted and protruding out into the amniotic cavity. This anomaly is commonly associated with genital abnormalities as well. What we'll see on ultrasound are the inability to visualize the urinary bladder, but we'll see normal kidneys, normal amniotic fluid. We may see a lower abdominal wall mass if the bladder is exteriorized or everted out from the anterior abdominal wall. So here's a fetus who had bladder exstrophy. There was normal amniotic fluid, but we saw a small mass inferior to the cord insertion in the midline. This is the everted bladder. Here's another case, but here we have the prenatal and the postnatal findings. We see the protrusion of the bladder from the lower anterior abdominal wall, and here's what it looked like at birth. Inferior to the umbilical cord was the everted bladder. Notice the bifid scrotum. This is a common anomaly associated with this. When ambiguous genitalia, such as a bifid scrotum, is identified, it's very important to assess the karyotype of the fetus or the infant. In addition, ambiguous genitalia is associated with a variety of syndromes and bladder exstrophy. So here is a fetus who has ambiguous genitalia. You can see a phallic-like structure protruding between two what could be hemiscrota. This did prove to be a male who had, by his chromosomes, and he had bladder exstrophy. So this is what it might look like. Here's a 23-week fetus with ambiguous genitalia. You can see the scrotum here and here is bifid, and that the penis is inferior to the scrotum rather than superior to the scrotum and pointing downward. And here's another male fetus with ambiguous genitalia. At 24 weeks gestation, we diagnosed a bifid scrotum here with the penis here. At 27 weeks gestation, we saw further development of the penis, but still splitting the scrotum. And by 33 weeks gestation, we now saw that the testicles had descended into this bifid scrotum that was separated by the penis instead of fused together beneath the penis. So I hope this information has been helpful to you, and I hope it will help you in your practice in assessing the fetus and its gastrointestinal and genitourinary tract. Thank you.